Hi everyone, it's Dr. Campbell and I'm back with another ICD-10 CM Coding Guidelines Review session. So today we are on Chapter 18. Can you guys believe it? We are working our way through those chapter-specific guidelines. So Chapter 18, codes R00 through R99, includes signs, symptoms, abnormal results of clinical or other investigative procedures, and ill-defined conditions regarding which no other diagnosis classifiable is recorded. Now, in those situations where you have a sign or symptom that points to a specific diagnosis, those are actually classified in other chapters of our classification system. Now, let's look at the use of our sign or symptom codes. In those cases where all we have is a sign or symptom, no diagnosis has been confirmed, you can code those. Also, if the patient has a sign or symptom and it is not associated with the disease, you can code it. If the sign or symptom is routinely associated with that disease process, you would not code that separately. So for example, maybe the patient has difficulty urinating and they have a urinary tract infection. That dysuria is one of the signs or symptoms of the urinary tract infection, so you would not code that separately. Combination codes. Guys, we actually have a number of combination codes that identifies both the definitive diagnoses and common symptoms of that disease. When you're using one of those combination codes, you don't want to put an additional code for the symptom because it's already included. All right, enough about signs and symptoms. Let's go to repeated falls. We have a code R29.6 for encounters when the patient has recently fallen and the reason for the fall is being investigated. We also have code Z91.81. That's when your patient has a history of falling, and this is for use when the patient has fallen in the past and is at risk for future falls. Now, when appropriate, you can actually report both of these codes together because remember, R29.6 says they have recently fallen. Z91.81 says that they have a history of falling. Next up, we have our Coma Scale codes, R40.2. These codes can be used in conjunction with our traumatic brain injury codes, acute cerebrovascular disease, or the sequela of a cerebrovascular disease. Now, one thing to note, these codes, when you look in your tabular listing at R40.2, you'll notice that there is a scale that's actually identifying different scores based on the patient's opening their eyes, their verbal response, and their mobile or motor response. These codes are actually primarily for use by a trauma registry, but they can be used in any setting where this information is being collected. This scale also may be used to assess the status of central nervous system for other non-traumatic conditions, such as patients that are in the intensive care unit, regardless of their medical condition. Your Coma Scale codes, however, should be sequenced after the diagnosis. Now, these codes, and there are three categories. Guess what those three categories are? Eye opening, verbal response, and motor response. They actually need a seventh character that identifies when the scale was actually collected. So was it collected by the ambulance? Was it collected on the floor by the neurologist? At a minimum, we should see the initial score documented on presentation at the facility. And again, it could come from the ambulance or it can come from the neurologist or another physician. Now, in those situations where the total score is documented in the medical record and not the individual scores, and what are the individual scores again? For eye opening, verbal response, and motor response. If you have the total score documented, we can use code R40.24. Of note, we do not report codes for individual or the combined score for a patient that's in a medically induced coma or for a sedated patient. Sidebar, there is a guideline regarding coma scale documentation for clinicians other than the patient's provider. We talked about that in an earlier video. Next up, SIRS, Systemic Inflammatory Response Syndrome due to a non-infectious process. So when SIRS is actually documented with a non-infectious process and no subsequent infection is documented, the code for the underlying condition, such as the injury, should be assigned, followed by code R6510 or R6511. Of course, and R6510 is Systemic Inflammatory Response Syndrome of a non-infectious organ without acute organ dysfunction. R6511, same condition, but we have a acute organ dysfunction. If the patient does have an acute organ dysfunction, you should assign the code for that acute organ dysfunction. Next up, we're going to look at death not otherwise specified, which is code R99. This is only for use in very limited circumstances when the patient who has already died is brought into our emergency room or other healthcare facility and they're pronounced dead upon arrival. It does not represent the discharge disposition of death, however. Last guideline, the NIHSS stroke scale, which are codes R29.7, can be used in conjunction with the acute stroke codes, which are code family I63, to identify the patient's neurological status and the severity of the stroke. The stroke scale codes, of course, are going to be sequenced after the acute stroke diagnosis. At a minimum, we should have in the record the initial score documented. And the facility at their discretion can capture multiple stroke scale scores. Sidebar, just like the Coma Scale, documentation by clinicians who are not the patient's provider. You can see your Section 1B14 guidelines. All right, guys, that has been your Chapter 18 review. Next up, guys, we got a big one coming up, which is Chapter 19, Injury, Poisoning, and Other Consequences of External Causes. That is a long one. Until then, guys, happy coding.